I'm Vincent Connolly. I'm Medical Director of the Emergency Care Improvement Programme. I work as a physician up in James Cook, up in Middlesbrough. And we're going to talk about, Ian and I are sharing a slot just now to talk about the clinical case for change. It's interesting to reflect on the story that Ipswich were able to tell us there. Colchester. We've got Ipswich this afternoon. We've got Neil Maloney from Ipswich this afternoon telling us about their journey. We've had Glenn telling us about what happened in South Warwick. Yesterday we had a team from Dudley, and their kind of strapline was, we were rubbish. If we can do this, you can do this. And you know, that's been a bit harsh on themselves, because you know, it's not ever that they were rubbish. It's that the stranglehold around people trying to do things differently is so strong. You know, the amount of observation, the amount of control over the system is really stifling our creativity and our opportunity to do things differently. We're getting frightened to do things differently because we're worried how it will be perceived and observed by others. And this programme is partly about giving back the opportunity to try and do that. It's going to be really difficult to kind of keep it and protect it in the way that it should be to really drive improvement. But that needs to be part of the aim of our programme team, to try and do that for you, to give you the space to do some of this stuff and see how it works. So we've heard from Jonathan Benger this morning talk about the urgent and emergency care pathway, its focus on the pre-hospital work, the connecting up of that to try and avoid admissions, and just to develop some of that a bit further and talk about some of the work that can happen internally within organisations as well. So here's a kind of image of what I want to focus on, which is the interaction between flow, occupancy and mortality here on the Indian Railway line. So we can see we've got a system here which is more than 100% occupied. We agreed? And we've got very slow flow because it just kind of chugs along the railway line nice and slowly. And the mortality rate on the Indian Railway line, some 15,000 people per year die on the Indian Railways. I don't know what's going to happen to these guys on the top if they ever reach a tunnel. It kind of doesn't bear thinking about. So one of the things that's really important, and I think has got lost a little bit in the emergency care debate, is that we focus very much on what we're being asked to do, which is 4 hours. And that becomes the kind of template for the discussion. The discussion is what we're trying to do is solve a problem around 4 hours. And because that's the what we're going to do, we've forgotten the why we want to do this, which Glenn's alluded to already. Why do we want to do this? And we need to go back and speak to our teams about the why, so that they get back on board with the message of what it is we're trying to do to make things better. And the why, obviously, is we want to improve outcomes for patients, whether that's mortality, whether that's getting them back to their own home. The how is we do that by getting senior docs in front of patients very quickly, supported by a team around them that enable them to make the very best decisions with patients. And the what is 4 hours in occupancy kind of fall out as a product of doing that really well. So I think it's really important we talk about that. Another example from looking through data sets that we've got is that I was looking at the delayed transfers of care. And there's examples in the data sets of where the delayed transfer of care has become the what of what we do is taking prioritisation. And there's been a focus on delayed transfers of care. So we've got trusts that have delayed transfers of care officially recorded at less than 2%. Well, if that was the problem, everything else would be solved, wouldn't it? But if you take a step back and look at Ian's metric of stranded patients, the same organisation, 60% of their bed days are used by stranded patients. So there's a real mismatch. So the focus, yes, we can get the detox down, it's missing the point. The point in getting the detox down is to reduce occupancy to enable flow to happen, and exclusively focusing on single nearly flocked there. Focusing on single measures really distracts us from the why we're here and why it is we want to do this. So if you were listening earlier, Jonathan Benger let slip the answer to this question, which is, what is the mortality for patients who arrive in a crowded ED 10 days later? Not in the ED, not in the EMU, not even necessarily in the wards. They might be home at this point. What is the increase in mortality? And in this study from Australia, a busy ED was defined by the staff's capacity to care for patients. So it was estimated in how many patients could staff look after, not the numbers of cubicles, trolleys, chairs, people in waiting departments. So can we have, don't know if everybody heard what Jonathan, he got it a little bit wrong earlier, but let's go. So hands up for 10%? No. 25? 40? 60? 40s and 60s? Yeah, you're all listening. Good. So it's 43% in that study. And we know that patients coming into crowded EDs is really dangerous. We know it's dangerous for mortality. We know that patients, they spend in ED leads to an increase in length of stay. So this study from the BMJ is from Ontario, but there's other studies from Western Australia and other places that show very similar message. And what this study's pointing out to us here is that in your left-hand panel is the adjusted odds ratio for death, and in your right-hand panel is the adjusted odds ratio for admission. And the axis on the left is every extra hour in the emergency department. So every extra hour in the emergency department, we see an increase in the odds ratio for death and an increase in the odds ratio for admission. And when we think through what happens in that type of environment, well, what else would we expect? Occupancy is interesting because there's a tipping point for occupancy where mortality starts to climb. And that seems to be around the low 90s in a study from Germany. So around 92% are there. Once you start getting above that level, your hospital mortality levels will start to creep up as well. So a real emphasising that link between flow, occupancy and mortality. And again, you know, our only kind of times when we get our kids off the computers and off their telephones is when we go on holiday skiing where they can't get on Wi-Fi, and we find out what they've really been up to for the rest of the year. But when we're out skiing, my wife is often heard to say, those boarders are going to kill me. And that was quite prophetic because this study from Scotland showed, yes, that being a boarder is not good for your health at all. The thing in Scotland where this data comes from is their definition of boarder, sleep out, outlier, whatever your local nomenclature is for it, is much stricter than we use in England. In England, our definition is a medical patient in a surgical bed, by and large. That's what we record as outliers. In Scotland, where it's sit-rep, it's on the sit-rep, it's if you're not in the consultant's ward that you're under. So you could be a diabetes physician and have a patient on a respiratory ward. The patient on the respiratory ward is an outlier. So it's anybody who's not in the consultant's base ward. And that really changes your definition, your thinking about it, and how that stretches the teams that are looking after those patients and why they have a worse outcome. A 4-day increase in length of stay for these patients. And when you think about it, the patients that are selected, in inverted commas, to be boarders or outliers are the ones that we think are going to go home soon or are safe to move. But we end up giving them a much longer length of stay. But worse than that, their mortality goes up as well. And as Jonathan mentioned, the patients that are left on the ward, they have a worse outcome because the staff in the ward that are looking after the other patients are now distracted with a task of organising multiple transfers to different parts of the hospital. They're not able to spend the same time with their own patients as well. So what do patients in hospital die of? Pneumonia is number one, stroke, heart disease, sepsis, urinary tract infections, lots of infections ones. So let's look at infection and why that's important. There are a number of clinical scenarios that we describe as time critical, where the interventions and the outcomes for patients are dependent on how quickly we do the right thing for patients. And we know that for MI, we know it for stroke, we know it for trauma. But one of the ones that hasn't had the emphasis wrapped around it that those three conditions have is sepsis. And we know from Daniel's work and now lots of others that if we do the sepsis 6, we give oxygen fluids, antibiotics, we check a blood count, check a lactate and do a blood culture in the first hour of the patient coming in, then will greatly improve their outcomes of the order of saving 15,000 lives in the NHS per annum. So we know we've got to do that consistently and systematically. The Royal College of Emergency Medicine monitor this. So it's an audit of what's happening in our EDs at present. And you can see in the middle there, the median achieved is somewhere around a quarter to a third for the individual interventions. As a package, it's probably below a quarter. So we are way off where we can go. And if we think about, well, our EDs are busy, there's a queue to get in, there's queues to get out of ED, you can't get people into cubicles. Well, you start to see why it becomes nigh on impossible to deliver the sepsis 6 consistently unless we get flow out of EDs. So what are the kinds of things that work in this type of environment? Well, the temptation again is to think about let's open more beds, let's expand the footprint of the hospital. We find that those interventions are rarely effective and often have the opposite effect for what they were intended. And if you look outside of our arena and look at other things where there's been great solutions to complex problems, you take this example here, which is where Microsoft and Carter developed their DVD model of referencing material for people to use and access for learning. How many people use Microsoft and Carter now? No one. It was taken off market because some bright spark thought, let's just see how many people out there are interested in developing a referencing tool that can be used all around the world and become the go-to referencing point. So how many people in here use Wikipedia? Yeah. They stopped making in Carter just about 10 years ago because they were up against it. They didn't have the resources of Microsoft. They didn't have the project management. They didn't go out and recruit international experts from around the world. They got willing, enthusiastic volunteers that really wanted to do something different. And the other one is the contraption developed by Samuel Pierpont Langley, who was a Harvard professor of mathematics, supported by all of that grants from the Smithsonian Institute. And this was his contraption that he hoped would fly. It was going to be launched by a large catapult that would get it from 0 to 70 miles an hour instantaneously. And what happened? It disintegrated and fell into the river. The guys that achieved flight worked in a bicycle shed. And they loved flying and the concept of flying. The Wright brothers from playing with toys when they were young. So we don't have to do everything in the very conventional, traditional ways that we're often forced into. So just to rattle through a couple of other things. This is a telephone in Cornwall. I don't know if it's reduced 999 calls. But we sometimes design interventions that are not unlike this. This is Little's Law. So Little's Law says that the number of patients in the system, the average number of patients in the system, is a product of the arrival rate times how long they wait. So if we can either deal with the arrival rate and get that down, we'll make an impact. If we can reduce the cycle time and the lead times in hospitals, then we'll reduce occupancy as well. So a couple of ways that we can do that. Well, most of the team in the NHS Elect that are here and with ESIST and Ian have been involved in developing ambulatory emergency care. We asked Nuffield Trust to do an evaluation of it. They've shown that the early cohorts achieved a marked reduction in bed days for ambulatory care scenarios, which has been maintained now over a period of 2 or 3 years by taking this type of approach and doing it differently. And we know from national data that the opportunity there remains enormous. So you might have an ambulatory care system in place, but keep pushing to see, is it delivering is it managing a quarter of your emergency referrals? Is it managing a third of your emergency referrals or more, as some systems are managing to do as well? We know that when Western Australia adopted a 4-hour standard approach and tackled exit blocks from the ED, they saw a reduction in mortality in their hospitals. We know that when Bernard Silk monitored his AMU development in Dublin, that he saw a 55% drop in mortality in the hospital through having systematic and consistent processes in the assessment unit that were repeatable day after day. That is a life saved for every 11 patients treated. So in a 50 or 60 admission assessment unit, you're looking at a really big impact on mortality. This is the work from Derby, which, similar to Glenn's unit in South Warwick, shows a drop in shimmy of around 9 to 10 points. The key thing here being their intervention was at 20 months, but it took 8 months for the mortality benefit to come through. So there's something about persistence and being able to see it through to the end to see the real benefits to patients. Interventions in the elderly. I think this is a real test of how well the system is working together. Because if the system's working together, we'll be able to achieve what Myton proposed in this paper, which was a 25 to 30% reduction in admissions for people over 75. But it requires real coordination across the healthcare system and is a real test as to whether we've achieved that and whether we're working really effectively together. Because one of the things that stops us is our tendency to point the finger down the chain at each other. Wards pointing their finger at the assessment unit saying, you know, why is this patient coming? Assessment units pointing their fingers at ED saying, why did they admit patients? ED pointing their fingers at ambulance for GPs, and et cetera, et cetera, et cetera. We work in an environment where we're almost set up to blame each other. So don't blame it on the sunshine, the moonlight, and the good times. You might as well blame it on the boogie. Thank you very much. I'm going to hand over to